Mike Gibson, Danielle Belardo, and we're talking about plaque and plaque regression. Danielle, we were talking just a day or two ago and talking about patients coming into your clinic, and you're like, you're going to show them their pictures. Pictures are worth 1,000 words. When you see that plaque there, it has an impact. I mean, how do you use cardiac imaging in your practice to drive change?
Yeah, great question. As you very well know, we have so much research that shows us that we can prescribe medications for patients, guideline directed medical therapy, and we still do not get the exact compliance, we really need from patients in order to reduce their cardiovascular disease risk. And as you know, also atherosclerosis, it's a chronic disease, it's a chronic dynamic disease, still the number one killer for men and women. And it evolves over decades with this plaque continuously forming, remodeling, changing composition. And one of the biggest things, like you had mentioned, that we can use to seemingly help our patients understand their cardiovascular risk is cardiovascular imaging. And when we talk about cardiovascular imaging, we have so many different options now to help show patients what is going on in their coronary arteries. One, of course, is something like a calcium score that shows us calcium, calcified plaque. And then, of course, we have, well, calcified plaque reflects this more stable, advanced disease, the presence of non-calcified plaque, and particularly low attenuation plaque, is strongly associated with future major adverse cardiovascular events. And these lipid rich inflamed lesions are biologically active and vulnerable to rupture, making them a critical marker of risk that goes beyond just stenosis and things like that. And especially in patients who I think where the vast majority of patients who find out the first time they find out they have cardiovascular disease may be at their first heart attack or stroke. Now with the advent of new imaging and imaging options, we can help to get patients on board with guideline directed medical therapy sometimes, before that happens, ideally.
So there's that first recognition that you have heart disease, and seeing that picture can be very important. But Danielle, how do you use the change in that picture to drive, and motivate patients to adhere to medical therapy?
Yeah. So one thing I think is really promising, especially, is one is showing patients, of course, anecdotally in my own practice, showing patients that there is plaque there, because for many people, especially people who are younger, and even if their plaque is not tremendously severe with regards to obstruction, they may be, even if they don't have symptoms, they may not have any day to day changes that they feel from having this plaque. So I think showing them that they do have coronary artery disease can be impactful for them to understand the importance of guideline directed medical therapy, but using a comparison. So, for example, using great AI, like Clearly, it's an AI driven platform that analyzes CT coronary angiogram, and it essentially provides this comprehensive quantitative assessment of coronary artery disease, and it helps to characterize and measure plaque burden, stenosis, the vessel morphology. And it actually integrates these metrics to even predict the likelihood of ischemia. And they have a great feature where they have a comparative feature where you can see the patient's baseline. And then when they start guideline directed medical therapy, you can track it and in a certain time interval repeat the scan and then actually see them side by side to see the impact and effects of their lipid lowering therapy. And as you know, plaque regression is one of those things that we have research for, and that is quite exciting. Plenty of people, of course, are most focused on just reducing major adverse cardiovascular events, and that is the gold standard. That is what's most important. But what if we could regress some of this plaque, especially that soft plaque? And we have the Glagoff trial that was a multi-center randomized double-blind RCT of about 1,000 patients with stable coronary disease that were already on statins. They were randomized to a PCSK9 inhibitor and versus just a statin therapy alone. And for them using serial imaging, they used IVUS, and they found that there was a modest but statistically significant reduction in percent atheroma volume with the patients that were on the addition of the PCSK9 inhibitor. So now we know that we have so many therapeutics we can use to help our patients reduce their risk for important things like heart attack and stroke. But to show a patient a comparative result of their prior CT to one in the future and show that some of, especially that higher risk plaque, that low attenuation plaque, their total atheroma volume, reduction is motivating. I have actually several patients that I've done this with, and one of my patients, sometimes in certain patients where they're young and the risk factors don't quite add up. And one of the examples I can think of is a patient in his early 40s, never a smoker, no diabetes, normal BMI, LDL always floating around the 130s, normal lipoprotein A, and normal blood pressure. This individual did have some chest pain. Wasn't sure if it was acid reflux or if it was coronary artery disease. Did a CT coronary angiogram and actually added on clearly and found that the patient they had a calcium score of 20, but they did have a significant amount of this atheroma volume soft plaque that was quite surprising for someone so young without any of the really red flag risk factors. And for that individual, we went aggressive. We went nuclear on his LDL. And in 2 years, his atheroma volume, total reduction was 18%. And so, we did get his LDL to 9. And so,
Sounds
getting
like me.
LDL,
Mine's 19 now, so I'm doing pretty good.
would you say?
I'm 19 now, just so you know. Doing
I
good.
mean, that's a number to be had. Yeah. So it's really, I think that is incredibly motivated for this patient because especially if you're young and you feel like, oh my goodness, this is only going to progress. This is only going to get worse. I find that at least for my patients, it's been highly motivating to show them the comparison and show them that guideline directed medical therapy works. And I look forward to trials being able to actually give us this information, whether or not this does increase adherence to medications, whether this does increase our outcomes for prevention. Because now in cardiology, it feels like we have all the tools in the toolbox, right? We have so many options for lipid lowering therapy, for blood pressure management, for weight management, for diabetes. We're in the best time for prevention that there's ever been. It's just getting our patients on the right medical therapy as well as getting them to buy into to staying on it.
Yeah. Well, many, many years ago, the first trial I ever did was called the HARP study, Harvard Atherosclerosis Reversibility or Regression Project. And we thought we were going to do this. We thought we were going to make blockages look better, but we only improved things by about 1% in the percent blockage. But now we have many more powerful tools like what you're describing, Danielle, looking inside the wall of the artery. And when you talk to a patient and show them their pictures, are you focusing on the amount of narrowing? Or are you focusing on the amount of soft, fatty stuff in those arteries?
Yeah, I think that it's a great question. And I think, just like you, it probably depends on exactly the patient's complaints and symptoms. If they have something that is narrowed, that is giving them symptoms, they're having chest pain with exertion, with exercise. Of course, that's a different conversation than a patient who may have wide open epicardial coronary arteries and no symptoms, but still some of that low attenuation plaque that really can be this, if we just do a calcium score, can be this invisible risk that we don't get to see. Have you had patients, because I sure have, that their calcium score is 0, but they are symptomatic or for whatever reason that, it's unclear whether it's acid reflux, whether it's musculoskeletal, and you do a CT coronary angiogram and you find a tremendous amount of soft plaque. And I've had this a handful of times that it's actually made me realize that, there is we know a lot in cardiology about our risk factors. And, generally, I think on a day to day, we can probably pretty much gauge our pre-test, likelihood for a patient to have significant coronary disease. But every once in a while, and not too infrequently, I am surprised by what we find in imaging. And I think of, wow, this patient whom I had the other day with a calcium score of 0, I was kind of, she had some symptoms that with a long-standing history of Barrett's esophagus, actually. So I said, let's just make sure it may be your, esophageal disease, but let's just make sure we're not missing anything. Calcium score of 0, but a tremendous amount of soft plaque. So I think that in these individuals specifically, even though she had nothing obstructive requiring any sort of intervention, normal ejection fraction, no diabetes, and her vessels with regards to ischemia were negative for ischemia on clearly, but it did change the amount of our guideline directed medical therapy we were going to go forward. And it turned out that the chest pain was likely from the esophageal disease. But in this
But
pathway, we caught it anyway and caught it early. And for someone who's 50, I mean, that changes the trajectory of their life.
it does. And, that soft plaque, if they go on a statin, that may turn into hard plaque, may turn into calcium.
Yeah.
So,
Absolutely. And so,
eh,
when we think about it with regards to that calcified plaque, that plaque stabilization, that's what we're hoping for. We're hoping
right.
for that plaque to stabilize and stay put and not go anywhere. But to the degree that we can get this high risk, non-calcified plaque and low attenuation plaque, the degree to which we can get any amount of regression is really, valuable and I think motivating for patients in some way, shape, or form.
Calcium score is a little bit of a mystery wrapped in an enigma that's a riddle topped in secret sauce. I mean, it is stabilized plaque, and it's not bad, but it's a marker of other soft plaques.
Yes.
So, well, I always learn so much from you. Thanks for joining us. Thanks to all of you for joining us here to understand how imaging and pictures can really drive patient behavior and how we can use it to our benefit. Thanks, Danielle.
Thanks again.